Okay, let's dive right into this explainer. Today, we're going to uncover a hidden danger that's probably lurking in the medicine cabinets of millions of seniors. We're looking closely at two of the most commonly prescribed blood pressure medications in the world. But listen, this isn't just some boring medical review. We're talking about what actually happens when these incredibly common everyday pills interact with an aging body. Because here's the crazy part. A prescription meant to save your life might literally be draining your energy, and you might not even realize it's happening. To really understand how this happens, I want you to look at this number, 46. This is where we meet Harold. He's a 72-year-old retired postal worker from Ohio. Now, for nearly 5 years, Harold took his blood pressure pill every single morning exactly as prescribed. He was the kind of guy who used to walk 3 miles before breakfast. But recently, he started spending his mornings just exhausted, stuck in his recliner. Then, one Tuesday afternoon, Harold stood up in his kitchen, his legs just completely buckled, and he nearly collapsed. When his daughter checked his pulse, his heart rate was a terrifying 46 beats per minute. You know, his family naturally assumed this was just a normal part of getting older, right? But it absolutely wasn't. It wasn't his age stealing his energy, it was his medication. Quietly, invisibly, one pill at a time, his daily prescription was actually slowing his heart down to a level his body simply couldn't safely sustain anymore. And honestly, this brings us to a massive blind spot in senior healthcare today. Which brings us to our first section, the post-60 body shift. So here's the thing. A medication isn't just inherently safe or dangerous in a vacuum. It depends entirely on your biological age. After 60, your body fundamentally changes. First off, your artery walls stiffen up and lose flexibility, which makes your systolic pressure, that top number, a whole lot harder to control. But it goes way deeper than that. Your liver, which processes pretty much every medication you take, slows down, meaning drugs stay in your system longer and actually build up at higher concentrations. On top of all that, your kidneys filter slower, your nervous system just can't react as quickly to sudden drops in pressure, and your heart becomes super sensitive to rhythm changes. So a dose that was perfectly safe at 55, it can quietly become toxic by the time you're 73. Let's move into our next section, Amlodipine versus Metoprolol. To figure out how to manage this, we really need to look at how these two very different pills work, starting with amlodipine. It's what we call a calcium channel blocker. Think of it like this. Every time your heart beats, calcium flows into the muscle cells of your artery walls, causing them to contract and tighten. Well, amlodipine steps in and blocks a portion of that calcium. The result? Your artery walls relax, they widen, and your blood pressure drops. This directly targets those stiffening arteries we just talked about, making it highly effective for that stubborn systolic pressure in older adults. But because of those biological changes, dosing is absolutely critical. For younger adults, doctors often start them right at 5 milligrams. But for seniors, the recommended starting dose is only 2.5 milligrams. And listen, this isn't just doctors being overly cautious. This is medical science directly respecting that slower senior liver we highlighted earlier. The body simply needs more time to process the drug, so any increases have to happen gradually. Okay, now let's shift over to metoprolol, which operates on a completely different pathway. Metoprolol is a beta blocker. Unlike amlodipine, which relaxes your arteries, metoprolol goes straight to the heart itself. It blocks the receptors that respond to adrenaline, which means the heart slows down and each beat becomes a bit less forceful. For a senior who has suffered a heart attack or maybe has heart failure, this reduction in oxygen demand is practically cardiac armor. However, there is a massive warning label attached to this cardiac armor. You must never stop taking metoprolol suddenly. Seriously, no way. Abrupt withdrawal can cause a highly dangerous rebound effect. We're talking about a sudden surge in your heart rate and blood pressure that can actually trigger severe chest pain or even a cardiac event. Any changes to this particular medication literally have to be incredibly gradual and strictly supervised by your doctor. To see how this plays out in the real world, let me introduce you to Eleanor. She's a 69-year-old retired teacher from Michigan. She had been taking metoprolol for 3 years and developed this crushing fatigue that made her feel decades older than she really was. So her doctor switched her to amlodipine. The fatigue lifted immediately, which was great. But within 6 weeks, her ankles swelled up so badly she couldn't even fit into her shoes. For Eleanor, it literally felt like trading one prison for another. And Eleanor's story perfectly highlights the trade-offs here. Neither drug is universally safe. Amlodipine is pretty notorious for peripheral edema, that swelling in the ankles and feet. It happens because it relaxes the arteries but not the veins equally, so fluid just kind of pools down there. It can also cause facial flushing or dizziness. On the flip side, Metropol's most frequent complaint is that heavy, crushing fatigue, alongside slowing the heart rate down to potentially unsafe levels, which can even lead to fainting. All right, let's move on to Section 3, the hidden interaction danger. You see, these risks don't just exist in a vacuum. They happen alongside everything else in what probably looks like your own personal pharmacy. The average adult over 65 takes 4 or more prescription medications every single day. Many take 6, 8, or even 10. Now, each one might be perfectly safe on its own, but when you dump them all into the same metabolic pathway, they start competing with each other. And that competition, it can turn a completely safe medication into a highly dangerous one. The science behind this competition comes down to things like the CYP3A4 enzyme. I know, it sounds like a robot part, but it's a specific liver enzyme responsible for breaking down amlodipine. But here is a wild catch for you. Certain antibiotics, antifungal medications, and even a single glass of everyday grapefruit juice can hijack this exact same enzyme. When that happens, the amlodipine isn't broken down properly, it just accumulates in your bloodstream, amplifying all those side effects like swelling and dizziness, creating a major fall risk that literally nobody warned you about. So, what do we do about this? That brings us to Section 4, clinical guidelines and solutions. So, with all of these side effects, changing bodies, and dangerous interactions, how do doctors actually choose what to prescribe? Well, the clinical guidelines from experts like the American College of Cardiology are actually quite clear. Amlodipine is positioned as the first-line treatment for seniors with uncomplicated hypertension, mainly because it directly addresses those stiff aging arteries. Metoprolol, on the other hand, is not recommended as a first choice for straightforward high blood pressure. Instead, it's really reserved for when the heart muscle itself needs targeted protection, like after a previous heart attack or if you're dealing with heart failure. And this is the absolutely crucial takeaway here. The right medication depends entirely on why your blood pressure needs treatment in the first place. The underlying diagnosis behind the prescription matters just as much as the prescription itself. Neither drug is inherently better than the other. The safer medication is simply the one that correctly matches your specific health history. Which brings us right back to Harold. After his terrifying collapse, his doctor took a step back and looked at his complete medical picture, his heart function, his age, his other prescriptions. They carefully transitioned him from metoprolol over to a conservative dose of amlodipine. And the results? Incredible. Within 2 months, his heart rate returned to normal, his energy absolutely skyrocketed, and he was right back to taking his morning walks and playing on the floor with his grandkids. Let's wrap up with Section 5, your medication toolkit. Harold's recovery wasn't a miracle. It was the result of asking the right questions. And we want to empower you to do the exact same thing. In fact, I'd love for you to grab your phone right now and take a picture of this screen to bring to your next doctor's appointment. Here are 5 essential questions you need to ask. Number 1, is this the most appropriate first-line option for my age? 2, what side effects should I watch for in the first 4 weeks? 3, has my complete medication list been reviewed for interactions? 4, is my target blood pressure actually adjusted for my age and health condition? And 5, how often should we reassess this medication or see if we can lower the dose? Asking these questions transforms you from a passive patient into an active, informed partner in your own healthcare. I want to leave you with this final, vital question to think about. Is your medication treating who you are today or who you were when the prescription was first written? Remember, never stop, start, or change any medication without consulting your doctor first. But please, take this knowledge, review your own prescriptions, and start that conversation. Thanks for joining me on this explainer, and we'll catch you next time.